But despite the fact that antibiotics seem very innocuous and they should, we should really be talking about antibiotics as a controversy, it still remains controversial. And that's probably because, I can just go back to the previous, somehow I've managed to move on the slides. I'm going to try and see if I can actually go back to the previous slide. Yeah, this is the slide that I wanted to highlight. This is one of the first slides on antibiotics done in 2006, which showed that the more you delay giving a patient with definitive bacterial infection, you're more likely to see poorer outcomes. And this is what triggered the whole thing about giving antibiotics in the first hour. And that's what it said. It was within the first hour. Unfortunately, even when this study was performed, it was noticed that only 50% of septic shock patients actually received their antibiotics at the right time. So by the time you've actually progressed to septic shock, you're actually developing hypotension. The situation is much worse. It's much better to make sure that your antibiotics are actually given as early as possible. But the problem is that we've actually looked at early antibiotics under the belief that it will actually save lives. What we haven't actually looked at is if the primary problem is not sepsis, and then you end up having a secondary impact of sepsis, does the same thing about a secondary sepsis starting off and giving antibiotics within the first hour actually improve outcomes? We don't really know that. Of course, it's now ethically not going to be possible to do a study on early versus late antibiotics because the 2006 trial basically said that you will improve, you save lives, and I'm sure you will not get any ethical approval to try doing another study around it. The other big controversial bit is fluids. You'd wonder why fluids would be controversial, because we predominantly give fluids to practically every patient that comes into hospital. And there's been obviously a lot of debate around whether you should be giving crystalloids or colloids, or you should be giving normal saline versus dextrose. That's been the focus and all the arguments around fluids. But fluids in sepsis appears to be more of a cult rather than a science. And this particular study, this isn't a study, this is actually a viewpoint that was published in Critical Care in 2012. And they were looking at fluid boluses and the resuscitation that we do in the emergency department when a patient with severe sepsis presents. And even the current guidelines recommend 30 mL per kilo of fluid resuscitation at first presentation to A&E with sepsis. And they basically quoted that as of 25th of May 2011, there are no studies that exist that compare initial resuscitation of patients with sepsis or septic shock with fluids versus no fluid boluses. So all the studies that have been done so far were basically comparing the different types of fluid. What they weren't doing was looking to see what happens if you didn't give anybody any fluids. And then, now this was as of 25th May 2011. As of 30th June 2011, there was a study published in the NEJM, which is called the FEAST trial, which basically looked at giving fluids and not giving fluids. But they did this in African children with life-threatening infections. And what they actually managed to enroll quite a large number of patients to this. And obviously they looked at no fluids versus saline versus, interestingly enough, albumin. And what they found was that actually if you gave fluids, you would have much more of a mortality than if you didn't actually give any fluids. So they basically, and this was actually consistent no matter which condition you actually had that was causing your sepsis. So if you look carefully here, if you gave no boluses, then it was much, much better. And this got everybody thinking as to, should we actually be blindly giving fluids to our patients as we normally do? And for those of you who've looked after COVID-19 patients or followed the literature since March to now about fluids in COVID-19, you would have noticed that when we started off, because COVID-19 caused ARDS, the patients were run dry, i.e. they were kept hypovolemic, and they ended up with a lot more renal failure requiring a lot more renal replacement therapy. Now that's in COVID-19, and that's obviously changed as the data has improved, and we now don't want them hypovolemic, we want them euvolemic. The problem is how to figure out whether you are euvolemic or not. So it's not about don't give any fluid, it's about making sure you give fluid at the right time to the right patient and give the right fluid. So moving on from that, what about steroids? Now, for those of you who look after sepsis patients, steroids has been a bit of a come and go thing. It's been a bit of a no-no for viral pneumonias. Yet, if you have been reading the papers, the study published for COVID-19 and the press release about the only drug that currently works in COVID-19 is dexamethasone, which is a steroid. So why did we get to this point and how? Now, steroids obviously have got benefits in sepsis, and that's a lot to do with the host response and the cytokine response that you actually see. So you can actually impact a lot of things and hopefully do good things in the interim. But this is a Cochrane review that was actually published in January of this year. So this is looking at corticosteroids in treating sepsis. And if you look here, it says that corticosteroids probably slightly reduce 28-day all-cause mortality in sepsis. They may result in little or no difference in long-term mortality. And corticosteroids probably slightly reduce hospital mortality. And if you look very carefully at the wording, it's all about probably, because at that time, the literature, all the evidence supported not using corticosteroids. And the surviving sepsis guidelines, which got published in May of this year for COVID-19, also categorically stated in mechanical ventilation, when ventilated patients with COVID-19 without ARDS, we suggest against corticosteroids. And even for those with ARDS, we suggest using systemic steroids. It was a very weak recommendation to use some systemic steroids, but that was more for treatment of ARDS rather than sepsis. But then we had this preliminary report from the recovery trial, which was actually published on Friday, which actually showed that if you gave steroids and low-dose dexamethasone at 6 milligrams per kilo to those patients that were mechanically ventilated, you saw much more improvement, and that's the mortality dropped from 41% to 29%. And the same applied to the patients who were on oxygen. It didn't actually improve mortality in those that did not require oxygen. In fact, it actually worsened their mortality. And that's one reason why dexamethasone has now been recommended as a 10-day 6 milligram course for any patient that gets admitted to hospital and requires oxygen and mechanical ventilation. And this is now a protocol in this trust. The other thing is obviously vitamins. Again, if you've been following the COVID-19 literature, there has been a recommendation to be using vitamin D in most populations, particularly in the BAME population. But vitamin D has actually been doing the rounds of critical care for quite a number of years. And this particular randomized controlled trial of vitamin D in severe sepsis was actually published in 2014, which didn't really show that it made any impact on outcomes from severe sepsis. Yet the joint statement on COVID-19 and vitamin D that was published a couple of months ago actually recommends people take vitamin D. I'm not sure whether this is as part of a treatment protocol, but it doesn't actually recommend it for patients. This is much more for healthcare workers. And then obviously we've got vitamin C. And the vitamin C reared its head in 2016 following the MARIC trial, looking at hydrocortisone, vitamin C, and thiamine. And in their small group of patients, they showed an improvement in mortality for patients that actually had vitamin C. The net result of that was it triggered the vitamins randomized control trial, which was published in the beginning of this year again. And this, unfortunately, did not show any improvement from giving vitamin C. So whilst taking any of the vitamins doesn't have much of an impact on your health, it might very well have some impact on your wallet. Now, moving forward from looking at some of the controversies, I just want to talk about a few disparities. Again, COVID-19 has brought to fore a lot of the disparities that we see. And the one that's been the most talked about, obviously, has been the impact on the ethnic minority group. And this is obviously from the latest ICNARC report, which actually showed that Asians and Black ethnic minority actually have a much higher mortality from COVID-19, despite the fact that that's not reflected in the viral pneumonias that we normally see over a 3-year period. It's still now, if you look back at it, it's still in keeping with what the white population has. So there clearly is something different about COVID-19 that is contributing to the mortality. We don't actually know why that is. There's a lot of hypothesis that's being floated currently, but we'll just have to wait and see where literature takes us with all of this. You wouldn't expect that there would be a gender disparity normally with sepsis. There's obviously a gender disparity with COVID-19, where you're seeing more men being affected than women. But actually, if you look at this particular trial, which was actually published just as COVID-19 kicked off, this is a single country, multi-site cohort study looking at gender disparities with sepsis. And what they found was women have a 1.3-fold higher odds of death at 30 days following an ICU admission for sepsis. Now, you'd ask the question is, why is this? Why is gender an issue with all types of sepsis? And is it along the same lines as COVID-19? It affects us differently. The belief from this study is that that's probably not the case. There are disparities in gender disparities in women with myocardial infarctions, with stroke. And it's actually been put down to the fact that most of the trials are done in men. All the scoring systems, all the methodologies that are used, and all the treatment modalities that are put forward actually look at an evidence base that's predominantly male rather than young women, because pregnant women in the age group where they can get pregnant are usually not included in quite a lot of the trials. So there is a level of disparity in how the trials are conducted in the first place. There's also the belief that when women present to A&E, they either try to be a lot more with more coping mechanisms about their illnesses and don't actually make as much of a fuss, probably, as men do. But this is very, very hypothetical. Nobody really knows whether that's a contributory factor to this. But the facts do remain that women don't quite get the treatment they need as fast as they need when they present to A&E. And in fact, if you look at the antibiotics, it's the women that are more likely to have delayed antibiotics than men. And that's clearly, while that is evidence, that's not actually clearly why the case might be. They've also, this is part of the COVID trials, obviously, which show that actually men are more likely to have a problem with COVID-19 than women are. The other thing is deprivation, and for the first time, the ICNARC report has actually looked to see whether deprivation actually contributes to higher mortality with sepsis. And yes, there is some evidence to support that the more deprived you are and you live in more deprived areas, you're more likely to have a higher mortality with COVID-19. So where is all of this taking us? And actually, it's looking into the future. Obviously, there's a lot of trials going on. There are a zillion trials actually going on looking at COVID-19, and hopefully will feed into sepsis. What it's also done is it's actually made our trials easier to run. They're randomized controlled trials, but simplicity, which is the ultimate sophistication, that's what we've actually managed to achieve with some of the trials. What we're also looking at is artificial intelligence. Now, there is some thought that's been given into this to say that actually if you had some kind of artificial intelligence algorithm, you might actually be able to diagnose and treat sepsis earlier, or rather at least within the time stipulated. Time will tell. But nothing in biology actually makes any sense unless you actually go back and look at it in terms of evolution. And that's purely because a living cell has actually survived for zillions of years. And in evolutionary terms, physiology is actually selected, and it is exceedingly complex. we are meant to survive somehow or the other, and whatever happens, evolution will see to it that that's what happens. Now, for those of you who actually follow Leslie Orgel and and are aware of their roles, he was basically a chemist who talked about evolutionary biology. And his first rule was, he only had 2 rules, and it's actually Francis Crick quotes him. And his first rule was basically that any spontaneous evolutionist that is slow will have a protein develop to make it faster. That's just how evolution works. And the bottom line is evolution is far more clever than any of us. And what we probably need to do is to look at physiological responses, which I'm not quite sure we actually understand as well as we'd like to think. But that's where we probably are currently in this whole paradigm of sepsis and COVID-19. Thank you.
Thank you very much, Ritu. That was a very comprehensive talk about the coronavirus and how it impacts on nowadays. Also, the concepts that you including touching on the lady. Somebody's speaking. Turn your mics off. Thank you. So thank you very much. I think it's Sam Folkard. Thank you very much, Ritu. It's incredible. Professor Martin Michaelis from the University of Kent is live. I can see him. He's done some recent research on COVID. Professor, are you able to talk? Martin?
Yes, I am. Yes, here I am.
Good to see you, Martin. You've done some recent work at the University of Kent on looking at the Cox virus. What can you share some of your experience?
Oh yeah, no, it's difficult to say, right? It's all guesswork still at the moment. I'd rather have a question, and that is an interesting one. But what do you think about the dexamethasone, and what is the actual effect? Because in a way, that's a very tricky thing, isn't it? Because if you're early, and somehow these results seem to show that if you're early, or if you're people who don't have serious disease, you inhibit the immune system, and that's not good if the virus is still replicating. But then there seems to be this tipping point when actually your immune system is going to kill you and not the virus. And to me, it seems extremely tricky to find the right point to use then an immunosuppressant. And I'm always curious from a therapist view, because obviously we just do these experiments and it's all very theoretical, but that's a huge decision. What do you make out of that?
Yes, I think you're quite right. I think when they first talked about dexamethasone being part of the recovery trial, even as a low dose as 6 milligrams, there was a lot of reservations from those of us who were participating in these trials to say, oh, why the hell are we doing that? Because over the years, steroids have actually got very bad press for viral pneumonias. And the reservations that we had were tremendous. The one good thing was that we were allowed to do it as part of a trial. So you almost felt that you couldn't be blamed for doing it because you were actually giving it as part of the trial. Ever since the trial results got published, there's been a lot of discussion around what is the right time to give dexamethasone, and is really a tiny dose like 6 milligrams of dexamethasone having that much of an impact on the cytokine storm in the body? I think time will tell on whether this actually still pans out to be the case. But by the time a patient actually presents to hospital and is desaturating, and that's one thing, if they're desaturating, there's clearly a significant cytokine storm taking place in their body. And targeting it at that point makes it technically easier for us to try giving dexamethasone. whether that is actually having a massive impact on suppressing the cytokine storm, whether these patients would have actually survived irrespective of whether we gave the dexamethasone, I don't think we've got an answer to that. But I think the problem with COVID-19 has been this complete lack of having any kind of treatment that we have on offer for our patients. This way, we at least feel that we are doing something. Whether it's good, we have no idea.
I have a question on that, and that then relates to obviously what you would need are probably biomarkers that really show you when you could use immunosuppressant. I've read controversial things about how long the virus is replicating, whether the virus is still replicating in the late stages or not. But what I've puzzled me so far is the question of antiviral therapy. So when you look about remdesivir, that seems to have some effect. And what I can say just from lab data, it is an efficient antiviral drug. It's not like chloroquine and hydroxychloroquine. These are notoriously basically infamous drugs because they seem to do a lot with do something with viruses in cell culture, but the therapeutic window is always so small that you can hardly believe that this can be achieved in patients. But when you have something like remdesivir, that seems to be quite a good drug from the data I've seen.
Well, is it? Because it gives the impression that it doesn't make any difference to mortality figures. Yes, it does reduce your length of stay on intensive care for about a couple of days, maybe up to 4 days. So it's still unclear whether that's happening because it's stopping the virus from replicating.
That's a good question, but my question I actually would have is, are there thoughts to use it earlier?
Well, we are actually using remdesivir earlier now. So we've started to use remdesivir as soon as a patient gets admitted to hospital and requires oxygen. So they automatically, if their renal function allows, will get dexamethasone remdesivir straight away. And if they have to test COVID positive to get the remdesivir. So it will be given anyways. So
in an ideal scenario, if you suppressed the virus replication earlier, you would prevent the cytokine storm. And
you hope you would.
Yeah, no, it's an effective antiviral drug, and that would be the hope. And I think that is the thing you should really
we are
try.
We're clearing it currently. We don't have enough data to tell us whether that's working or not. The problem is that remdesivir is being used quite a lot in outside of the UK because we came into using remdesivir quite late. So Asian countries have actually had remdesivir for a slightly longer period of time, and they have obviously been using it for much longer. The problem is they've actually been using everything. So you've been using dexamethasone, you've been using remdesivir, you've been using tocilizumab. So when you suddenly use everything together, you have no idea what's actually working. And that's not part of a trial. That's just being done because people feel the need to save lives, and they try to throw the kitchen sink at the patient, and that's what it appears to be.
And that's a problem. But when you, I think I've been puzzled from the beginning with the late remdesivir because there is, it's like an influenza. Yeah, we know they've known this for a long time. At some point, your immune system kills you, and not the virus. And then whatever antiviral drug you would have will be too late.
The thing is, again, one of the questions that keeps coming up is, does your own immune system really kill you?
Oh yeah, yeah. That's what people say. I don't know.
Yes, exactly.
That's what people say. It's the cytokine storm. It's also all a simplification, right? The cytokine storm is not exactly the immune response. There are elements of the immune response. There are others. But at some point, it's probably not the virus anymore itself, but the reaction in an organism that causes a lot of the damage. I guess that's fair to say.
Well, it's the virus that triggers the response, and then the virus dies, but the response has already caused the damage. and so has the virus. Again, these are just hypothetical questions. It's just interesting to realize just how there is so much we don't really still know about sepsis after 3,000 years of having it.
So, Martin, thank you. Very, very pertinent questions. Ritu, I have a question for you.
Yeah.
So what about the role of other immunosuppressants or immunomodulators? For example, colchicine. Is there a role for colchicine?
Well, the thing is, currently for colchicine, I've not actually found any evidence to support the use of colchicine, but they're actually looking at quite a lot of immune modulators, particularly things like interferon. So currently it appears that using interferon may actually have some benefit. Having said that, people are even looking at things like heparin, anything, and apparently giving nebulized heparin might actually stop the thrombosis that COVID-19 actually causes, and that might improve your outcome. So currently, you name the drug, it's being looked at.
Okay.
Unfortunately, we don't really have enough evidence to support quite a lot of these drugs being used. The good thing is that the drugs that we already have, people are making so much of an effort to research to see if there's anything out there that, like dexamethasone, that can easily be implemented in a clinical setting to see whether that's actually going to make any difference.
Sure. And what's your take on the latest information about the phase 1, phase 2 trials from Oxford about the vaccine? Do you have any reservations about the information that's being given out at the moment? Is there an acceptable optimism? Or
there's some level of optimism, and I think the very fact that they've managed to show that the vaccine actually helps with T-cell immunity as well, because so far it was all about antibody generation.
Yes.
Rather than anything else. And now when they found that there was a level of T-cell immunity that was contributing to COVID-19, we would probably need a vaccine that will actually impact that as well. It's quite nice to see that that's going in the positive direction. So if you'd asked me the same question 2 weeks ago, I would have had a hell of a lot more reservations. But going forward, it seems to be ever so slightly more optimistic. I don't suddenly want to feel, oh yes, we're going to get a vaccine and we'll all be sorted.
Yes.
But at least it appears to be moving in the right direction.
Sure. Well, one of the things is that it seems to be safe. So that's the first thing.
We won't know that till these people in the trial actually get infected.
Yes.
So let's wait and see whether that happens.
There weren't any adverse, major adverse reactions.
Yeah. It's about 1,000 patients, so it's a case of waiting and seeing. Yeah.
And then the second thing is that some form of immune response was clearly detected.
Generated, yes.
So there is cause for optimism.
At the bottom line is, for us as a race to survive COVID-19, we have to have a level of optimism, because if we give up now, we will get nothing in terms of treatment options at all. So we have to maintain our optimism to allow future development and for future treatment modalities for COVID-19.
Absolutely. Thank you. From a surgical point of view, I can see Ed Streeter online. Ed, can you hear us? Ed? I think the microphone is not working.
Worked out unmute.
Yeah, can you? Yeah, hi, Ed. With this pandemic, as surgeons, we had some reservations about operating on patients as aggressively as we used to before in terms of our waiting lists and stuff. You have anything to add about that? What's your take on operating on patients during a pandemic?
Well, so I personally, as you know, Sash, have had to continue doing cystectomies on people, one of whom was unlucky enough to become infected whilst in hospital. There is some data, obviously of variable quality, to suggest that patients are increasingly at risk, particularly after major surgery, if they contract COVID in the recovery phase. No one knows exactly how much risk that sort of confers onto the patient, but it's obviously a major concern if you're already at risk of major chest problems already. It is something we've had to take on board, measures taken to try and protect the patients as far as possible. It is obviously a balance of risks, isn't it, at this stage, whereby if you can't wait 3 months or 4 months or a year, however long it's going to take for us truly to be safe, to operate on someone and you clearly can't wait that long for a cystectomy, then one has to do what one can to protect the patient.
Yeah.
I mean, I think we've done everything we can in terms of isolating patients, screening patients, isolating people, and now testing staff as well. How much
Yeah.
risk is there? If you look at the statistics now, one would say that we are pretty safe if you believe the government's figures on. I've had this conversation, and maybe that's why you've asked me. But you know, if you look at the government statistics on the population prevalence of coronavirus now, and you add in the isolation, the screening, the symptomatic questionnaires, the chance of us operating on someone unknowingly with COVID is 1 in 50,000 or less. So, you know, I think it now becomes a very real question of patients being delayed treatment is more dangerous than taking all precautions and proceeding. So that's
Yes.
on it, actually. And I think we are duty bound to try to keep our services running as far as we can, but as safely as we can, obviously. But I don't think we should be denying people treatment based on coronavirus with what we now have available.
Absolutely, and I share your views. Thank you, Ed.
Yeah.
David Stafford. David, can you hear us? David is one of our uro-oncology nurse specialists. Can you hear us, David?
Yeah, I can. Hi, Ritu.
Hi, David.
David,
Hi,
you were one of those guys who were deployed as a frontline. What was your experience?
So I think that it was very surreal to be. It was staggering to be witness, really, of really an enormous redeployment of staff from all backgrounds and levels of experience. I think that what it demonstrated was that when all the teams work together with a single focus, the enormity of change that can occur in such a short space of time is quite, humbling to be part of, really. I think that, I'll be interested to hear Ritu's thoughts on, because she's a clinical leader and is very heavily involved in making sure that the staff are okay and that they're, in terms of their sort of psychological well-being. And I'll be interested to know how, she anticipates, a second wave and how, she's preparing to maintain that resilience to, anticipate it.
Ritu, you have an answer?
Yeah. Well, I think resilience is overrated to start off. The thing is, I think COVID-19, the impact of COVID-19, we haven't quite appreciated it among staff members. And I've already seen quite a lot of clinical staff suffering from the equivalent of PTSD from this. And a second surge is going to have a major, major impact unless we actually find ways of ensuring that our staff get the required rest and recuperation prior to the next surge. So the bottom line is, firstly, of us accepting that there is going to be a very large mental health crisis amongst healthcare workers going forward, particularly those who've actually been on the front line already, and finding ways and means of mitigating it. The good thing is that this has been anticipated, and the government, GMC, Royal Colleges, everybody is trying to ensure that there is some level of therapy available for people to access, and a lot of this is free. But at the end of the day, it's for us as individuals to be supportive of our colleagues, because there is nothing better than peer support. And that's going to be absolutely vital going forward. And because we are in a position to understand what our colleagues are going through, and it's very, very important that we support and don't belittle any of their concerns and their mental health issues. Which would be my absolute take-home message from this, is that if you can be there, sometimes all it takes is a conversation. It doesn't have to be any more than that. And just to give the impression that we are there, you can come and talk to us anytime and we will help. And that's the only way going forward that we'll be able to manage the surge.
Absolutely. Well, thank you everyone for joining us. Everyone has clinical sessions and other things to go to. Ritu, once again, thank you very much.
For inviting me.
I want to thank the NIHR, the various research teams, and the University of Kent School of Biosciences and the entire staff here at East Kent Urology and the anesthetic department also for joining us. And next week, we're going to restart with our cancer biology series. And Tobias van der Haar from the University of Kent will be talking about some exciting developments about RNA and the impact of that on cancer biology. So thank you very much, everyone. You take care and stay safe.
Thank you, everyone. Bye.